So the next presentation, and there are a couple of people just leaving the room now, is entitled Life and Peer Navigation for People Newly Diagnosed with HIV. Now, I understand that Chris, if you'd like to come up, has worked in Queensland HIV, the sector itself, for over 20 years. He's lived with HIV for over 30 years. He's the Life and Program Manager for Queensland Positive People. If I could ask that those of you who are leaving right now, if you could avoid conversation until you leave the room, I think that will make it easier for everyone to hear. And Tico is a peer navigation team leader in Brisbane. He is studying for a master's degree in health management at Queensland University of Technology. And prior to that, he finished his medical degree in Indonesia. So please welcome both Chris and Tico to the stage.
Hello everyone. I might make a start while they try and bring up the presentation. So thank you for the kind introduction. You know who I am. Firstly, I just wanted to acknowledge the traditional custodians on the land upon which we meet and pay my respects to elders past, present and emerging. I'd also like to acknowledge our key funders for the peer navigation program. Queensland Health has been a significant contributor, Vive Healthcare, the HIV Foundation, the University of Queensland School of Population Health, and also our sister organisation in Canada, in British Columbia, Positive Living British Columbia. So a little bit about our organisation. This is just an overview of the presentation. The historical role of peers in the HIV response. So for those of you who don't know what HIV is, it's the human immunodeficiency virus that causes AIDS or AIDS-acquired deficiency syndrome. Peer navigation, we're going to talk about the contemporary role of peers in the HIV response. We'll talk about the peer navigation model that we developed. We'll hear from Tico in particular around his perspectives as a peer navigator, and we'll look at peer navigation from now and beyond. So a little bit about us as an organisation. So we were founded in 1989, essentially to support people living with HIV across the state of Queensland. Our vision as an organisation is to improve the health and well-being of those people living with HIV across Queensland, and encourage individuals to be informed and empowered and to live lives free from stigma and discrimination. Our mission as an organisation is to provide a comprehensive range of services that meet the health and wellbeing needs of individuals living with HIV, and ensuring that these are delivered in accordance with internationally recognised best practice. And peer navigation model, which I'll talk about, is actually one of those. I mentioned that the model was made possible through a number of different funding sources and is adapted from an internationally recognised best practice model that is provided in Canada. So I just want to talk a little bit around the historical context of the role of peers in the HIV/AIDS response. So for some of those of you in the room who might remember in the early 80s the emergence of AIDS in particular, it required a very significant involvement from the community. The people living with HIV and those that were dying from the virus were actually the carers, they were the educators, they were the advocates, they were the activists, providing social, emotional and practical support to their friends, their colleagues, their loved ones. And it was done primarily from a position of volunteerism. So those individuals were really not paid for that work. There was a lot of stigma, a lot of fear, a lot of ignorance around HIV and AIDS, so it really required a community-driven response. So stemming from, for those of you that I don't know if you know of the Ottawa Charter that was developed in 1986, following on from that was a principle that was endorsed globally, which referred to the greater involvement of people living with HIV. And essentially this evolved over time to not only greater involvement, but really a meaningful involvement of people living with HIV, essentially utilising their lived experiences, their personal experiences to inform the broader HIV response. And that was founded on some key principles about local responses to HIV, that policies and programs were tailored and responsive, and that there was a focus on self-determination and personal empowerment. So this is a diagrammatic, and I'm sorry, it's a very, very busy diagrammatic view, but this is actually the JIPA model. The key principles are the branches of the tree, and the leaves form the actions, the recommended actions. So if anyone wants the link to that to have a look at closer in depth, I'd encourage you to come and see me. But it's a really, really fascinating model to implement in practice.
Chris, could you just tell us what JIPA stands for, speaking of acronyms?
So it stands for the greater involvement of people living with HIV and AIDS. And MIPA stands for the meaningful involvement of people living with AIDS. So I just wanted to turn our attention towards looking at how HIV has changed over the years. So in 1983, the HIV virus was identified by a number of clinicians. And then so basically until 1996, there really wasn't any effective treatment for the management of HIV, and a lot of people, unfortunately, succumbed to the virus and died. But in 1996, there was some groundbreaking evidence, clinical evidence, as a result of extensive trials that demonstrated that triple combination therapy, so that's the utilisation of a number of different therapies, was very, very effective in suppressing the replication of virus in the body. So what we did see was the number of people that were living with HIV started to increase, and the number of people dying from HIV declined. Then very rapidly, over the past few years, we've seen some very significant advances in treatment. And there were some major milestones, and I won't go through them, but they're essentially here on the slide. But really the take-home message from this slide is that there was resounding evidence that early intervention or early treatment following a diagnosis of HIV not only prevented disease progression in an individual, but also prevented onward transmission of HIV. So there were two key elements which is now known as TASP, or treatment as prevention. So I'll just reiterate that. That's the prevention of disease progression in a person living with HIV and the prevention of onward transmission. So in 2013, the United Nations AIDS Committee, part of the World Health Organization, on the basis of treatment as prevention, developed some modelling to basically say that by 2020, if they had 90% of people that actually knew they had HIV, that was their target, and that 90% of those people that knew that they had HIV that were actually treated, and then 90% of those people that were treated for their HIV had undetectable virus, that is, that the medication suppressed the virus so that it was not infectious, that they could virtually see the elimination of HIV by 2020. So what that essentially informed was some strategic focuses for, I suppose, there was the global United Nations AIDS targets of 90-90-90, and then there were strategic objectives which were embedded in Australia's national 7th National HIV Strategy, which is currently being reviewed for 2018, and also the Queensland HIV Action Plan. So these principles became embedded as strategic objectives in all these levels of planning. So as an organisation committed to the health and well-being of people living with HIV, we identified that there were a number of ways that we could respond to support those strategic targets, but also support the health and well-being of the PLHIV population. So we developed two distinctive programs, one of which is a peer testing clinic. So this is where peers in our community test those most at risk of HIV for HIV and other STIs. And we have a clinic in Brisbane and one on the Gold Coast. And we also developed the Life Plus program, which was about addressing the other two 90%. So that's 90% of people living with HIV would be on treatment, and 90% of those people would have undetectable viral load. So I'm very happy to say that the model that we submitted to the department in 2015, which was looking at an integrated suite of programs, was actually funded, and the department for the first time recognised that a PLHIV peer-based organisation was best placed to respond to the holistic needs of people living with HIV across Queensland. So some of the other services that we provide in addition to case management, in addition to peer navigation, is complex case management for individuals living with HIV, health education, information and resources, and stigma and discrimination. So the broader goals of the program are actually listed on this slide, but I think that most of the goals are achievable through the peer navigation program, and a particular focus for us is preventing HIV disease progression in PLHIV and improving the overall quality of life of our peers. I talked a little bit earlier around how peers have always been central to the HIV response, and primarily in the role of volunteerism. This slide here just models where peers now fit within the broader response to HIV. So we work in the peer navigation program alongside health professionals to help people newly diagnosed with HIV to synthesise that diagnosis into their lives by the provision of an early intervention model for individuals following a diagnosis. So, as is the process for any program development, there's a very logical, sequential flow. But I really wanted just to highlight that individuals living with HIV were at every step along the way of this process and engaged in the focus testing and the development, in the delivery. So PLHIV were involved at every point. I'm now going to hand over Tico to talk a little bit about the model and the lived experience.
Thank you, Chris. So if we look at this picture, the white person in the middle is newly diagnosed. And you can imagine how complex and overwhelming it is once you are diagnosed with HIV to navigate the HIV care and treatment. So what we did is that we did a needs analysis result to identify the information and support needed for that person. And the results of that analysis are basically, one, about information. People need not only about information about diagnosis, treatment, and navigating HIV care, but they also want information about disclosure, about legal rights and responsibility, and other topics. In regards to support, they want someone who can provide emotional and social support, and can help to put their diagnosis into perspective and help to ease their fear and anxiety of becoming an HIV positive person. What's really interesting is that apparently they want this information and support to come from a trained PLHIV peer worker, and they want to meet this peer worker in a face-to-face setting, and they want it right from the get-go since day one of diagnosis. So what we did is that we created this model in which client is at the center of our model, and then we have 3 integral parts starting from the peer support, in which in this part, the peer navigator will use their lived experience as an HIV positive person to provide that emotional and social support. And in the navigating health system part, the peer navigator will help them to build trust with the doctors, how to access treatment through the pharmacies, and how to understand their pathology lab results. And through the peer education, the peer navigator will deliver information by using educational modules. These educational modules basically categorized into 2 categories. The first one is the core modules, and the second one is elective modules. For all clients, they have to go through the core modules, in which they will talk about HIV one-on-one. They understand the virus, and then the treatment, and then navigating the health system. But when it comes to the elective modules, they get to select which topic they want to discuss. And that's because in delivering these educational modules, it is based on the adult learning theory. Now, the intervention itself is very highly structured. It's 15 hours for a client, and that can range from 4 to 8 weeks. And then it's very flexible in terms of setting. They can, the peer navigator can go to the doctor's appointment with the client or meet at a coffee shop. And what's important is that towards the end of that engagement, the peer navigator will assess whether the client is actually confident to manage that diagnosis and whether there are other issues that need to be referred to a case manager. Now, because we need to provide a very good quality, safe, and culturally appropriate services, we have peer navigators all across Queensland. Mostly they are in Brisbane, but we also have in other regions as well. We have females, we have heterosexuals, there are people peer navigators from Africans, Aboriginal, and Asian background, and they also have other lived experience from mental health issues, alcohol and drugs, and also homelessness, so that we can address that intersectionality issues within the clients. And when we provide training, and then we provide the skills development and also ongoing supervision to make sure that the service that we provide is safe and is of good quality. So for me, how do I work within this model? For me, being a peer navigator is about empowerment. I empower the clients and I empower myself. So I have to bore you poor people about a little story about myself, in which I came to Australia last year as an international student to study master degree in health management, and I was diagnosed just 1 month after I got into Australia. And then I have to navigate the Australian HIV care, which is so simple to understand, and that's an understatement. And of course, unfortunately, there's a QPP who helped me to understand that and how to better manage my diagnosis. And in June, I applied for the job to become a peer navigator to work with people who don't have access to Medicare. Now, what we have to understand is that prior to that, I'm just a consumer. I'm a consumer with a very complex issue, just like any other consumer. But starting as a peer navigator, this consumer can provide services to other consumer. And after working a while, I discover even more complex issue with my home country, in which there is a persecution towards the Indonesian LGBTs. And so I applied to become a refugee here in Australia. And so since December, I'm basically an asylum seeker. But thankfully, with my job as a peer navigator and my study, I keep on going, and I find myself now as a team leader of this peer navigation team. And right now, I'm presenting in front of you all, not only as a peer navigation team leader, but also as an HIV-positive gay Asian asylum seeker. So, thank you. I mentioned about people who don't have access to Medicare, in which apparently there's another term, Medicare ineligible, because obviously we need more terms. So Medicare ineligible is people who basically have a working visa, student visa, working holiday visa, or holiday visa. They can't access the Medicare, and therefore they cannot access the HIV treatment. And the HIV treatment itself, it will cost about $1,000 until $1,500 a month. That's the first regimen that the doctors prescribe. So we have to find other ways for these people to be able to access treatment. Now, if you look at the building blocks on the top, that's the story that we want all people living with HIV to go through. They got diagnosed, they are linked to the care, they retain their linkage to the care, they committed to the treatment, and then they achieve that viral suppression or undetectable viral load, in which in their blood, the volume of the virus is really low. But for Medicare ineligible, they have access to navigate that various access to treatment. It's really difficult, it's not straightforward. And then there is a financial barriers that I mentioned, and then there's a low health literacy because it's not easy to understand a healthcare system in a foreign country. And also they have to navigate complex migration system because a lot of them wants to become permanent resident, but to become permanent resident, if you are an HIV positive, you basically just fail the health requirements and you have to waive that health requirements. Very complex. So basically, up until now, I've supported 10 Medicare ineligible clients out of 76 peer navigation clients. And most of them are males, most of them come from Asian countries, and most of them hold student visa. But what I consider as a big achievement for QPP and for the peer navigation program is that all of them started treatment within 3 months. And that's the goal of our programs. And we're very proud of that because we've been working hard to achieve this. And we got amazing feedback, like people saying they're really confident now in managing their HIV. That's rarely happens. It's like we're giving a fast track process to people to achieve that level. And so I guess the benefits of being a peer navigator for me, it's all about empowerment, like I said. I, as an asylum seeker, get to develop my skill, apply what I studied about quality improvement, people management, program evaluations, and this is the skills that Australia needs. And I get to contribute to the Australian society in general and PLHIV in specific, and I'm proud of that. So to discuss more about the outcomes and challenges and future plans, please, Chris.
Thank you, Tico, and thank you very much for sharing your very personal story. Look, just going to touch quickly, since the peer navigation program has been up and running, as Tico indicated, we've had 76 clients, 10 of which have been female and the balance male. Interestingly, the main the demographic there for the age range aligns with, of course, the epidemiological data from Queensland Health. It's a very concerning fact for us as a PLHIV organisation that we continue to see the rate of diagnoses amongst Aboriginal and Torres Strait Islanders to increase, and that's represented in this slide that 10 of the people that we've supported since the peer navigation program has developed have been Aboriginal and Torres Strait Islanders. So I just want to talk, a little bit about...
Just check no one's getting dripped on. Oh, it's the speaker. All right, thanks, great. Sorry, Chris.
That's okay. I just want to talk a little bit around some of the challenges. I didn't want to necessarily paint the implementation and operation of this program as being plain sailing. We've certainly had our challenges in employing peers to work in the role. Some of those challenges have been peer navigators working within their scope of practice and stepping outside of that in doing, as you can appreciate, peers work in this role for altruistic reasons and they're really wanting to help their peers. They sometimes go a little bit far, so some boundary violations have occurred. We have had peer navigators through their lived experience that bring great strength to their role, that have a prior history of drug and alcohol misuse. We have seen some peer navigators triggered and relapsed. So the need for intensive support, ongoing supervision, and the retention in alcohol and other drug programs or mental health programs are really critical to ensure the health and well-being of our peer navigators. Supervision and support is challenging for a geographically dispersed team of peer navigators right across the state. And we play, I did correct this misspelling, but it's not causal employees, it's actually casual. But casual employees, so each engagement with a peer navigator is 3 hours. So we pay them at a casual rate, but under the award, it actually can be quite expensive. So that's an ongoing challenge. Technology use also. So all our peer navigators are armed with mobile phones and mobile tablets. And for some peer navigators, it's been a real challenge in terms of utilising that technology and also data entry. We capture quite a lot of data. We're partnered with the University of Queensland for an evaluation of this project, so that does require the inputting of data as well as our reporting to Queensland Health. So basically future plans for peer navigation. So we're extending the program to those at risk of falling out of care. So what our case managers identify as some of the clients they're working with are at high risk of actually falling out or disengaging of care, and in care, and they identify a significant value or that a peer navigator can actually provide for a time limited period. So we're extending the program to that. We're strengthening the capacity of all peer navigators to work with Medicare and eligible PLHOV. So TECO will be developing module development for training all peer navigators, given that Medicare and eligible peer navigators are across, Medicare and eligible PLHOV across the state. And the thing that's probably stood out for me in the development of this program is that one size doesn't fit all, and I think in recognition of that is tailoring and adapting the program more specifically to meet the needs of Aboriginal and Torres Strait Islander people. We talked about this as being an early and brief intervention model. Well, that just doesn't work for some Aboriginal and Torres Strait Islander identifying people. So we acknowledge that we really need to work with the community to adapt the model in a more suitable way. What I can sort of say, and it's not on this slide, is that we have been successful in securing funding for Townsville to implement a further innovation, which is a HIV STI peer tester, as well as peer navigator position, which will sit within a health service within the Townsville region. So that has been, it's a pilot project, it has been funded, but yet to be implemented. So take-home messages really from here are that peers have always been central to the HIV/AIDS response, as I said earlier, and today, and we have a vital role to play to support the global achievement of those targets. We, as individuals within the community, we're here to empower and support our peers, and peer navigation really does that in a really proactive and constructive way. And the model continues to adapt to the changing needs of our consumers, essentially, and to our other key stakeholders. So basically questions if we have time.
Yeah, we most certainly have time. Tico, would you like to join Chris? Does anyone have a question? I'll bring the microphone to you. One, Steve, down the back.
Chris and Tico, thank you for a very educational presentation, and obviously the innovation to establish a peer network needs to be congratulated and continued. I actually am HIV positive and have been since 1983, and during the 80s and 90s we undertook a major public education program, and I worked across multi-sectors then. And there was a degree of success, although the program didn't actually focus, say, Aboriginal and Torres Strait Islanders, and was lacking in that respect. I'm just wondering, is there room today for a more prolific or higher profile public education program? Because we are seeing, certainly in North Queensland, some rise, particularly in STIs, and certainly HIV in Indigenous communities. I'm just wondering what, if any, strategies you or others might be planning to raise the bar in terms of public education.
Thanks, Steve. So the question was really what are we doing as an organisation to raise the profile of HIV, particularly in Aboriginal and Torres Strait Islander communities? Would that be a fair? STIs, yeah. Look, our role primarily as an NGO is really to work with people already living with HIV. In terms of the prevention space, the government has funded other organisations to work in that area, and particularly with the money that the minister's committed to the Aboriginal Torres Strait Islander health strategy for the North, of the $15 billion. It's really hopeful that there's something very, very constructive that comes out of that. We're very keen to partner where we can. We have an Aboriginal Torres Strait Islander peer navigator in Cairns that currently provides outreach support to Townsville. And as I said, we're very keen to continue to develop and adapt the model to ensure that it's more appropriately meets the needs. I think the thing that, as an early intervention model, the idea of peer navigation is to help people synthesise a diagnosis into their lives and prevent the risks of falling out of care. And we do know that Aboriginal and Torres Strait Islanders are at greater risk of falling out of care. So that's why this program, but we understand the real complexities of engaging in the community and needing to be sensitive to the individual needs. Yeah.
Any other questions? Oh, we've got 1, 2 and 3. So, and just to let you know, the lovely Helen went out and checked, and unfortunately there's nothing we can do about the dripping sound, so apologies if that's distracting.
Hi, thanks for the presentation. It was wonderful. I'm interested in the peer navigator model as it's adapted to other kinds of diseases and conditions. And the one thing that I'd like to ask you, I've got a lot of questions, but the one thing I'll ask about is, what do you do about the boundary breaches where the peer navigator, outside the scope of their practice, how is that handled, and what have been your main issues with that?
So the question was peer navigation adapted to other healthcare settings?
I think everyone can hear now. We're using the microphone.
Okay,
is that
cool.
correct? No, sorry.
So there are two questions. One relates to peer navigation within other healthcare settings.
Mainly the second part.
The second part. boundary violations. They're lots of fun. So I'll pass that over to Tico.
That's right.
We'll come back to that part. Tico.
All right. Okay, so just repeat the question. The question is, how do we handle when there's a breach of boundaries from the peer navigators themselves? So there are a couple of layers, just like any other quality improvement strategy. You cannot depend on just one method. So one is that we provide formal supervision every 2 months. So that's to talk about a lot of things, including engagement with clients. And then there's an informal feedback that I always give to the peer navigators every time I see a warning sign. So that can be from the report that they just wrote, and then if I sense there's a gut feeling that it's just not right, I always tell my peer navigators that I'm going to be open and honest about it, and then we're going to have a discussion about it. And then also I always encourage the peer navigators to plan and then seek approval and then act. So if they kind of thinking about a strategy that they want to utilize to engage better with the client, and then they're not sure, or they may be overtly confident about it, have a chat with me first. Talk to me and then see what plan do you have, and then we discuss that. And then, so that's how I mitigate the risk of boundaries. But when it already happened, you don't punish. You don't use punishment as a center of the philosophy of managing a breach of boundaries. But instead, it's about open and honest discussion with client as the center. So we have to get a clear information about what happened to the client, and then we need to be clear about how the peer navigator responds to that, and then we created a plan of action from that information.
Yeah, look, thanks, Tico. I might just add that where people have relapsed back into drug and alcohol use, basically we support those individuals to engage in a treatment program. They're basically, they step outside or step aside from their role until such time as they're stabilised. And we're also very cautious about how we link those people. So we don't link those peer navigators necessarily to people that may trigger some of those behaviours. So it's a really important, and our board, as you can appreciate, wanting to ensure that that risk is managed. Some of those other challenges are where we have peer navigators in rural and regional communities that socialise and sexualise in those environments. So, through social media and other mechanisms. So we provide very clear guidance and support around that, and as always with any sort of ethical or boundary issue, we always encourage them to seek guidance and support and be open. In terms of adapting peer navigation to other healthcare settings, I believe it's done quite widely within the mental health sector, and in HIV it is done in the UK, in Canada and in San Francisco, I believe. So yeah.
Thank you, Chris. We are fast running out of time. So what I might do is the two people who indicated that they had a question, ask them to ask their questions, and if you can respond very briefly to both of them, that would be great.
I guess I was interested in the opportunity, especially for your volunteers, your peer navigators, to transition over into doing that sort of support work in other areas. So,
okay, and we've got one more up the front.
By that question, yes, so certainly the board are very keen to explore the expansion, for example, peer navigation for injecting drug users, for example, maybe for sex workers, for other most marginalised and at-risk groups to help, basically support those individuals to engage in care.
Okay, I was just wondering if you had incorporated within your peer navigation models those that are suffering from hearing voices, which is associated with paranoia, and blaming the HIV as an external factor coming from such thing as the devil. instead of understanding it's a human-acquired causal. So I was wondering if what are you incorporating within your peer navigation models as into assisting these people? Because I don't see them in mental health units at the moment.
Yeah. That's a very complex question, but essentially we really work with an individual around exactly where they're at as an individual. So, for example, we've talked very specifically about a very pro-treatment approach, but as an organisation of people living with HIV, we respect an individual's choice to choose whether they engage in treatment or not. And similarly, that relates to how they perceive the acquisition of HIV and so forth. So where we identify that there may be other ongoing issues for that individual, it may sit outside the scope of practice of a peer navigator. So we'd be very keen to explore how we might work with that individual about providing other supports through case management program. So we want to ensure that what we're providing, peer navigators are safe in the work that they're doing, and we respect the duty of care to ensure that we're providing the best support to appeal HIV. Yep.
Fantastic. Can we thank Chris and Tico for their fascinating presentation and also for their courage in sharing so much about their own lives and experience? Thank you.